Assalamu alaikum dear students. Welcome to Dr. Roomi lectures. In today's session, we will discuss past university questions from insulin, glucagon, that is the pancreatic hormones, and how blood glucose level is regulated during 24 hours, and also diabetes mellitus, its metabolic changes in the body, and important complications of diabetes mellitus. These past questions are both from physiology and biochemistry, and by knowing the answer to these questions, you will be able to answer these questions if you get these questions in physiology paper or biochemistry paper. Our very first question is, give an outline of insulin structure. Insulin, when it is synthesized, initially it is proinsulin, which is inactive, stored in vesicles. Within these vesicles, which are made by the Golgi apparatus, proinsulin is broken down into one molecule of C peptide and one molecule of insulin. Insulin is a protein hormone which has 51 amino acids. It contains two chains, A and B chains. A chain contains 21 amino acids and B chain contains 30 amino acids. It's important to note that these two chains are joined together by disulfide bridges. And when these two A and B chains are removed, then the activity of insulin is lost. C peptide and also proinsulin do not have the activity of insulin. Next question is, what is the mechanism of action of insulin? As you know, insulin is a protein hormone. Its receptor is present in the cell membrane of its target cells, and its mechanism of action is enzyme linked receptor mechanism. Insulin receptor is a tetramer which has two alpha subunits which are present on the outer surface of the cell membrane, two beta subunits which pass through and through the cell membrane. When alpha subunits bind with insulin, then the beta subunit is activated. The inner part of the beta subunit has tyrosine kinase activity. When activated, this will autophosphorylate itself, and then a series of enzymes inside the cell are also phosphorylated. Phosphorylation of enzymes inside the cell causes activation of some of them and inhibition of some of them. A group of enzymes called as insulin receptor substrate, which is also activated, is also responsible for several actions of insulin. One immediate action of insulin is to translocate GLUT4 transporters from inside of the cell using the membrane vesicles into the cell membrane, and then some intermediate actions they occur by the activation and inhibition of some enzymes. Some late actions of insulin are by affecting the expression of some genes, and this affects the growth and some other anabolic effects. So important point to note is that insulin receptor has tyrosine kinase activity, and its receptor uses enzyme linked mechanism. Next question is, how insulin secretion is regulated. Most important factor that stimulates the insulin secretion is glucose. After taking a meal, when blood glucose level is high because carbohydrates are being digested and absorbed, this glucose enters through GLUT carrier into the beta cells, and this is not dependent on insulin. Glucose, once inside the beta cells, it is glycosylated and ATP is formed. This ATP blocks the potassium channels. Potassium diffusion out of the cell is blocked. Inside the cell become depolarized, which opens voltage gated calcium channel. When calcium enters into the cells, that triggers the vesicle to release this insulin through exocytosis out of the cell. Other factors which increase the release of insulin are amino acids, for example, arginine, free fatty acids, also an intestinal hormone, GIP, which is called as gastric inhibitory peptide, or glucose dependent insulinotropic peptide. Glucagon hormone also increases insulin secretion directly by paracrine effect and indirectly by increasing the blood glucose level. Growth hormone and cortisol also increase insulin secretion. Sulfonylureas, a kind of oral anti-diabetic drugs, for example glimepiride, also block potassium channels just like ATP, and hence increase the release of insulin. So that's why these drugs are also called as secretagogues, which means they increase the secretion of insulin. Some factors that decrease the release of insulin from the beta cells of pancreas are somatostatin. Some factors that inhibit the secretion of insulin from the beta cells of pancreas are somatostatin, which also inhibits the release of glucagon hormone through paracrine effect in the islets of Langerhans. Norepinephrine, by acting on its alpha adrenergic receptors, also decreases the release of insulin. It's important to note that when we are in a state of emergency, then there is need to increase our blood glucose level. So that's why insulin level must be low, because when more insulin is released, then it decreases glucose level. So that's why we don't need any more insulin. We need less insulin so that less glucose is sent into the cell and more of it is available for the brain. Next question is how 24-hour blood glucose level is regulated in a normal person. Why it is important to regulate blood glucose level? It's important because some tissues in our body, they are only dependent on glucose as a source of energy. For example, brain tissue, the retina of our eyes, germinal epithelium of gonads, also red blood cells, renal medulla, and bone marrow. They exclusively are dependent on glucose for their energy needs. In order to understand the regulation of blood glucose level, we need to understand the sources of blood glucose, which means where glucose comes from, and also the utilization of glucose, where glucose is used. First, the sources. So the first source of glucose is the dietary carbohydrates, which are digested to give you glucose. 80 to 90% of the digested carbohydrates make the end product glucose. Just 10% is galactose and mannose, which is also converted to glucose. So this increases your blood glucose level. Another source of glucose is glycogenolysis. When we are in a fasting state, then the glycogen which is stored in our liver is broken down by the action of glucagon hormone, and this glycogen provides blood glucose. And if our fasting is prolonged, then gluconeogenesis is also increased in our liver. So this converts lactate, glycerol, and amino acids into glucose. Now, where glucose is used, when we have more glucose in our blood, for example, after taking a meal, extra glucose is used for oxidation and producing energy through glycolysis and the Krebs cycle. Extra glucose is also stored in our liver and muscle in the form of glycogen. If we have further more glucose, that will make fatty acids, and there will be increase in fat synthesis, which means lipogenesis will be increased. Some glucose can also be used in the hexose monophosphate pathway to make pentoses and also to increase the synthesis of NADPH. Utilization of glucose is increased by the action of insulin, and blood level of glucose is increased by the action of many anti-insulin hormones like glucagon, thyroxine, growth hormone, epinephrine, and cortisol. All these anti-insulin hormones are also called as diabetogenic because increased level of these hormones increases the risk of diabetes mellitus. Here it's important to note that glucagon has most of its actions only on liver. This increases gluconeogenesis and glycogenolysis. Epinephrine has actions both on liver and muscle, and this increases glycogenolysis. Cortisol increases gluconeogenesis and it also decreases the peripheral utilization of glucose. Growth hormone decreases the entry of glucose by the peripheral tissues. It also decreases the use of glucose as a source of energy. So by the action of insulin and anti-insulin hormones, our blood glucose level is normally regulated. Fasting level of our blood glucose is between 7 to 100 milligram per deciliter, and after taking a meal, the blood glucose level is between 120 to 140 milligram per deciliter normally. Next question is, what are the physiological actions of insulin? And now in this case, you have to write the actions of insulin on carbohydrate, lipid, and protein metabolism separately. First, the actions of insulin on carbohydrate metabolism. Insulin increases the entry of glucose into cells, adipose tissue, and skeletal muscles. Insulin also increases the entry of glucose into the liver, but not through GLUT4 mechanism, but by increasing the utilization of glucose. It increases glycolysis and Krebs cycle, which means oxidation of glucose, and it also increases the storage of glucose in the form of glycogen. At the same time, it also decreases glycogenolysis. It also decreases gluconeogenesis, and the extra glucose is stored in the form of lipids as well. So lipogenesis is also increased. On proteins, insulin increases the entry of amino acids into the cells. It also increases protein synthesis. It decreases the use of amino acids as a source to make glucose, so gluconeogenesis is also decreased. It also decreases protein breakdown. So insulin has protein sparing effect. Insulin's action on lipids are that it increases the de novo synthesis of fatty acids. It also increases the synthesis of glycerol 3-phosphate in adipose tissue. It also increases the synthesis of triglycerides, so lipogenesis is increased, and at the same time lipolysis is decreased. Insulin also increases the entry of potassium ions into the cells. Next question is, define gluconeogenesis. How gluconeogenesis is suppressed after feed and enhanced during fasting. Gluconeogenesis means formation of new glucose from non-carbohydrate substances. Some important sources for making new glucose are glycerol, lactate, and amino acids. Insulin decreases gluconeogenesis after taking a meal, and this is by suppressing some enzymes. The enzymes which are suppressed by the insulin are pyruvate carboxylase, phosphoenol pyruvate carboxykinase, and also glucose 6 phosphatase. During fasting, glucagon increases gluconeogenesis by activating all these enzymes which are suppressed by insulin. So, glucagon increases the conversion of pyruvate towards phosphoenol pyruvate, and then the backward reactions of glycolysis they are increased, and this way glucose is formed. The final reaction in which glucose 6 phosphate is converted to glucose, that is by the action of glucose 6 phosphatase, is also activated by the action of glucagon. Next question is how insulin regulates lipogenesis. So insulin increases the entry of glucose into the adipose tissue through GLUT4 transporters. This increases the formation of glycerol 3-phosphate. Glycerol 3-phosphate is very important so that it can bind with fatty acids and makes triglycerides. Where does fatty acid come from? By two mechanisms. Number one, the same fat which we have taken will be digested and then the chylomicrons will move to liver. Liver also synthesizes VLDL. These VLDL and chylomicrons which are rich in triglycerides, they come to peripheral tissues through the blood circulation. At the endothelium of blood capillaries, there is an enzyme called as lipoprotein lipase. The activity of this enzyme is increased by insulin, which increase the release of triglycerides from chylomicrons and VLDL. These triglycerides are broken down and give the fatty acids to the adipose tissue. Fatty acids bind with the glycerol 3-phosphate to make triglycerides once again. And also there is increase in de novo synthesis of fatty acids by the liver. The rate limiting step in this case is conversion of acetyl coenzyme A to malonyl coenzyme A, and the enzyme required is acetyl coenzyme A carboxylase, which is stimulated by the action of insulin. Insulin also stimulates HMP shunt and hence the formation of NADPH, which is an important reducing power required for the synthesis of fats. Next question is name the hormones that produce gluconeogenesis and ketogenesis. Gluconeogenesis is increased by diabetogenic hormones like glucagon, growth hormone, epinephrine, cortisol, and insulin decreases gluconeogenesis. Ketogenesis can be increased by hormones such as glucagon, cortisol, thyroid hormones, and epinephrine. Because these hormones they cause lipolysis and increase the release of fatty acids. The use of these free fatty acids in the beta oxidation process is increased and hence increase in formation of ketone bodies, that is beta hydroxybutyrate and acetoacetate. Insulin decreases ketogenesis. Next question is what are the differences between physiological features of insulin and glucagon hormones? Glucagon is produced from the alpha cells of pancreas and insulin from the beta cells. Most important stimulus for secretion of glucagon is hypoglycemia, and for insulin it is hyperglycemia. The net effect of these two hormones on our blood nutrients are that insulin decreases glucose level, decreases amino acids level, decreases free fatty acid levels, and also decreases ketone body level. And the net effect of glucagon on blood nutrients are that it increases our blood glucose level, increases free fatty acid level, and increases keto acid level, but decreases amino acids. The major sites of action of insulin are skeletal muscles, adipose tissue, and liver. And for glucagon, the major site of action is liver. Insulin increases glycogen synthesis, glycolysis, lipogenesis, and protein synthesis. And all these metabolic activities are decreased by the action of glucagon. Glucagon hormone increases glycogenolysis, gluconeogenesis, lipolysis, and ketogenesis. And all these metabolic reactions are decreased by insulin. Next question is briefly describe oral glucose tolerance test or OGTT. What is its diagnostic significance? Diagnosis of diabetes can be made on the basis of individual's response to the oral glucose load. This test is usually done in the morning before taking a meal. Person is given 75 gram of glucose dissolved in 300 ml of water, and this is given over a time of 5 minutes. Blood sample is collected before giving the load of glucose and also after giving this glucose load with a 30 minutes interval, at least up to 2 hours. The person is said to have impaired glucose tolerance if his blood glucose level in fasting is between 110 to 126 milligram per deciliter. And also impaired glucose tolerance if after 2 hours of the oral glucose load, the blood glucose is between 140 to 200 milligrams per deciliter. These people having pre-diabetes are at increased risk of developing diabetes later on. A person is said to be suffering from diabetes mellitus if his blood glucose level in the fasting is more than 126 milligrams per deciliter or after oral glucose load is more than 200 milligrams per deciliter. Next question is, how do we diagnose diabetes mellitus? Diabetes mellitus can be diagnosed if a person is having symptoms of diabetes like polydipsia, polyphagia, weight loss, polyuria, along with fasting glucose level more than 126 milligram per deciliter. Or the person will also be diabetic if the random blood glucose is more than 200 milligrams per deciliter along with the symptoms of diabetes mellitus. If a person has glucose level more than 200 milligram per deciliter after oral glucose tolerance test, he will be declared diabetic if glucose level is present along with other symptoms. When the symptoms of diabetes are not present, then can we declare a person diabetic based on just single glucose determination? The answer is no. At least another glucose test must be done on some other day with a value in the diabetic range. Next question is, describe the role of HbA1c as a biochemical index or marker in the diagnosis and control of diabetes mellitus. HbA1c is a type of hemoglobin. Its normal concentration in our blood is 3 to 5%. However, its level increases in case of hyperglycemia. When more glucose is present in our blood, more hemoglobin is glycosylated and its level increases. Because the lifespan of red blood cell is up to 120 days normally, so that's why this hemoglobin will stay there in our blood for 3 to 4 months, and this will tell us about the control of glucose during last 3 months. If a person has HbA1c level between 5.7 to 6.4, he is in pre-diabetic range, and a level equal to more than 6.5% will be declared as in a diabetic range. So, for a diabetic person who is taking anti-diabetic treatment, the desired level of HbA1c for better control of diabetes is less than 6.5%. Next question is, differentiate between the features of type 1 and type 2 diabetes mellitus. Type 1 diabetes mellitus is 10 to 20%, type 2 is 80 to 90%. Type 1 is usually in children who are less than 20 years old. Type 2 is predominantly in adults who are more than 40 years old. The body weight in type 1 diabetes is usually normal or less, but in type 2 diabetes, body weight is increased, so people are obese. Genetic predisposition for type 2 diabetes is very strong. In type 1 diabetes, it may be mild. If we talk about some biochemical parameters in type 1 diabetes, the insulin production from the beta cells of pancreas is deficient. In type 2 diabetes, the insulin secretion may be normal or increased because insulin resistance is also present in type 2 diabetes. Auto antibodies against the beta cells of pancreas are frequently found in type 1 diabetes, but they are rare or absent in case of type 2 diabetes. Ketosis is very common in type 1 diabetics, it's rare in type 2 diabetics. However, type 2 diabetics are more likely to have hyper or smaller coma in case of uncontrolled conditions. Acute complication in type 1 diabetes is ketoacidosis. The symptoms of type 1 diabetes develop rapidly over weeks if not treated, and in case of type 2 diabetes, the symptoms are prolonged for several months or even years. At the time of diagnosis, type 1 diabetics rarely have complications, but 10 to 20% of type 2 diabetics they are already having complications at the time of diagnosis. Because oral hypoglycemic drugs like sulfonylureas they increase the release of insulin from the beta cells of pancreas. As beta cells are not functioning in case of type 1 diabetes, so that's why oral hypoglycemic drugs are not useful in the treatment of type 1 diabetes. However, they are important stay of treatment in case of type 2 diabetes. Insulin is always administered in case of type 1 diabetes for the treatment. In type 2 diabetes, usually insulin is not required in early treatment, but later on it may be required. Type 2 diabetes may be associated with other endocrine disorders, but other endocrine disorders usually are not present in case of type 1 diabetes. Next question is, a 50-year-old man consults a physician. He has complaints of increased volume and frequency of urination, thirst, and increased appetite. He also gives history of generalized weakness and weight loss. His fasting blood glucose is 160 milligram per deciliter. Which disease this man is suffering from? What is the physiological basis of increase in urinary volume and frequency, increase appetite and thirst? Another similar scenario is 13-year-old boy presented to the physician with complaints of increase in frequency of urination, thirst, appetite. He also gave the history of generalized weakness and weight loss. On examination, he was dehydrated and there was smell of acetone from his breath. Random blood glucose was 370 milligram per deciliter. Name the condition he is suffering from. Give physiological basis of increase in frequency of urination and thirst, dehydration, weight loss, and acetone breath. In the first scenario, most likely diagnosis is type 2 diabetes, and in the second scenario, most likely diagnosis is type 1 diabetes. Now, I will describe the physiological basis of the signs and symptoms asked one by one. Polyuria is increase in urine formation. This increases the frequency of urination, and this is because of osmotic diuresis, because the blood glucose level is increased. When this glucose level increases the renal threshold, which is 180 milligram per deciliter, then all the glucose filtered from the kidney cannot be reabsorbed. Some starts appearing in urine, and glucose being osmotic brings water along with it in urine, and this increases urine formation and hence increase volume and frequency of urination. Polydipsia is increase in thirst. This is because osmotic diuresis causes loss of excess water along with glucose. This also increases the blood osmolarity because of high blood glucose level, and high osmolarity stimulates our osmoreceptors which are present in hypothalamus. Third center of the hypothalamus is also stimulated, and this increases the desire to drink water. So that's why uncontrolled diabetic feels thirsty most of the time. Next feature of diabetes is polyphagia, which means increase in appetite or increase in food intake. You know that brain does not need insulin for the entry of glucose into the cells. However, the satiety center in our hypothalamus needs insulin for the entry of glucose into the cells. When there is less insulin or less insulin action, less glucose is entering into the cells of satiety center in the hypothalamus. Hence, this satiety center will not be stimulated. When satiety center is not stimulated, it cannot suppress the hunger center in the hypothalamus. Hence, hunger center will be overactivated, and this will cause the person feel hungry most of the time. Why these diabetics have weight loss? This is because of increase in proteolysis and lipolysis due to insulin deficiency, which leads to a catabolic state. Acetone breathing in diabetic patient is because of increased lipolysis, which increases formation of free fatty acids, which when oxidized increase ketone bodies in liver. These ketone bodies are beta hydroxybutyric acid, acetoacetate, and also acetone. Acetone is volatile and this is expired out. It has characteristic fruity odor. Next question is hyperglycemia and ketoacidosis are the hallmark of untreated type 1 diabetes mellitus. Give biochemical cause of hyperglycemia and ketoacidosis in these patients. So biochemical cause or mechanism of hyperglycemia in uncontrolled diabetic patient is decrease in the action of insulin, which decreases the entry of glucose into the peripheral tissues, muscles and adipose tissue. There is less utilization of glucose in glycolysis and Krebs cycle. There is also less storage of glucose in the form of glycogen. Moreover, the glycogen breakdown by the action of glucagon is increased, and also there is new synthesis of glucose through gluconeogenesis, and all these effects increase blood glucose level, hence causing hyperglycemia in diabetes. Next is the mechanism of diabetic ketoacidosis. You know, diabetic ketoacidosis is a very important complication which can be seen in a type 1 diabetic patient. In case of insulin deficiency, glucose cannot be used by the peripheral tissues as a source of energy. Hence, fats and fatty acids will be used as source of energy. In case of insulin deficiency, there is increase in triglyceride breakdown, so there is more formation of free fatty acids. Moreover, there is less synthesis of fatty acids and less synthesis of triglycerides. When we have too much fatty acids in our blood, they are given to the liver, and liver converts these fatty acids into ketone bodies, and hence leading to ketoacidosis. Another question is a patient having uncontrolled diabetes mellitus develops ketoacidosis, the cause of which is the increased delivery of fatty acids to liver. The fatty acids are derived from increased lipolysis in the adipose tissue. How lipolysis is increased in this patient? In diabetes mellitus, there is less action of insulin, which decreases the uptake of glucose. by fat cells. Hence, there is less formation of glycerol. Moreover, there is also less synthesis of fatty acids, less synthesis of triglycerides. There is also inhibition of enzyme which converts acetyl coenzyme A to malonyl coenzyme A. Hence, de novo synthesis of fatty acids will be decreased, and the enzyme which is not stimulated in case of insulin deficiency is acetyl coenzyme A carboxylase, which is a rate limiting enzyme for fatty acid synthesis. So, hence, fatty acid synthesis will be decreased. Moreover, lipolysis will also be increased by the action of glucagon hormone. Lipid storage is also decreased by decreasing the action of insulin. This is because glycerol is less in the adipose tissue. Decrease in insulin also decreases the activity of lipoprotein lipase, hence the storage of fatty acids in the adipose tissue will be decreased. So in case of diabetes mellitus, decrease in action of insulin and increase in action of glucagon hormone decreases lipogenesis and increases lipolysis. Next question is describe the metabolic changes that occur in diabetes mellitus. Carbohydrate metabolism is changed in a way that there is increase in blood glucose concentration, increase glycogen breakdown, and increase gluconeogenesis. Moreover, the peripheral use of glucose is also decreased. In case of protein metabolism, there is increase in protein breakdown, increase in catabolism of amino acids which are used as a source to make new glucose. So gluconeogenesis is also increased. There is also increase in ureagenesis because the amino groups removed from amino acids will be used to synthesize urea, and there is decrease in protein synthesis. In case of diabetes, there is also increase in lipolysis, decrease in lipogenesis. So fatty acid synthesis is decreased and the beta oxidation of fatty acids are increased, which increase the ketone body formation. Next question is list and briefly explain the long-term effects or complications of diabetes mellitus. Prolonged hyperglycemia in diabetes mellitus causes dysfunction of several tissues, and the development of these complications is directly proportional to the degree and duration of hyperglycemia. However, the patients with well controlled diabetes can postpone the development of these complications or reduce the rate of progression of these complications. Major diabetic complications are macrovascular and microvascular complications. Atherosclerosis in larger vessels causes their narrowing. In heart, the coronary artery narrowing can cause angina and myocardial infarction. Generally, the narrowing of arteries can cause hypertension by increasing the vascular resistance. In case of brain, the narrowing of vessels and sometimes the rupture can cause stroke, and the peripheral artery narrowing can cause ischemia of the legs, or sometimes it can cause gangrene of the foot. Microvascular complications can also cause degenerative changes in various organs. In case of retina, it can cause diabetic retinopathy. In kidneys, it can cause diabetic nephropathy. And in case of nerves, this can cause diabetic neuropathy. Neuropathy can cause numbness of lower extremities, which can increase the risk of infections leading to gangrene. This discussion of university questions from insulin, glucagon, and diabetes mellitus will be useful both for physiology and biochemistry from examination point of view. Thank you for watching the video. Please like and share. See you next time with another video.